Imagine a patient presenting with that nagging, debilitating joint pain.
We see it all the time.
They've tried rest, ice, perhaps some over-the-counter painkillers, but nothing's quite cutting through.
The usual first steps haven't worked.
Exactly. So what's the next logical step in our orthopedic toolkit, the intervention that can often provide that crucial window of relief?
Well, often that points towards considering injections.
Precisely. Today, we're taking a deep dive into corticosteroid injections for joints and musculoskeletal soft tissues.
It's a foundational topic, definitely.
It really is. It's a frequently utilized intervention in orthopedic and musculoskeletal practice, but one that absolutely warrants, well, a nuanced and evidence-based understanding, doesn't it?
It certainly does. The details really matter for safe and effective use.
And guiding us through this vital topic is an expert with extensive experience and a profound insight into the evidence-based application of these treatments, Professor Moimom. Professor, thank you for joining us to unpack this for our listeners.
It's a real pleasure to be here. This is, as you say, a conversation we have daily in clinical practice. And truly understanding the nuances of these injections is absolutely key to making the best decisions for our patients.
Our mission today is to truly unpack the evidence, the fundamental mechanisms at play, the practical applications, and crucially, the safety considerations surrounding corticosteroid injections.
Getting right into the detail.
Yes, we want to equip you, the medical professional listening, with a comprehensive, up-to-date perspective to inform your clinical decisions and ultimately enhance patient outcomes.
Absolutely. Knowledge into practice.
So let's start at the very beginning. When we hear corticosteroid, it's a term we use frequently in medicine. But what exactly are these powerful agents? How do they exert their profound anti-inflammatory effects right down at the cellular level?
That's an excellent question, and it really is the foundation, isn't it? Because understanding how they work is fundamental to appreciating their role.
Right.
Corticosteroids, things like cortisone or prednisone, are essentially synthetic versions of cortisol.
The body's own stress hormone.
Exactly. Cortisol, as you'll know, is a natural hormone produced by our adrenal glands, and it's a crucial player in the body's own system for managing inflammation and stress.
Okay.
So when we introduce these synthetic corticosteroids, their primary action is quite profound. They work to limit the dilation and permeability of our capillaries.
Tightening up the leaky pipes, so to speak.
In a way, yes. Think of it like tightening the tiny blood vessels that are typically allowing fluid and inflammatory cells to leak into an injured or inflamed area. By doing this, they directly reduce the influx of key inflammatory cells, specifically those first responder immune cells like polymorphic nuclear leukocytes and macrophages to the site of injury.
Okay, so stopping the reinforcements arriving.
Precisely. But their action doesn't stop there. They also restrict the release of various vasoactive substances and destructive enzymes.
The chemicals that cause more damage.
Yes, these are the compounds that, as part of the inflammatory cascade, can actually cause further damage to surrounding healthy tissues.
I see.
And here's where it gets particularly interesting with more recent research. There's compelling evidence suggesting that corticosteroids inhibit the release of arachidonic acid from phospholipids in cell membranes.
Okay, that sounds technical. What does that mean practically?
Well, in simpler terms, arachidonic acid is a crucial precursor to prostaglandins.
Prostaglandins, key players in inflammation and pain.
Absolutely. They're incredibly potent drivers of inflammation, pain, and swelling. So by essentially cutting off this supply line, corticosteroids effectively reduce the production of these major inflammatory mediators.
Right.
So it's this multi-pronged attack, reducing cellular influx, limiting destructive enzyme release, and cutting off prostaglandin production that allows corticosteroids to powerfully alleviate those classic symptoms of inflammation: redness, swelling, heat, and crucially pain.
It's a remarkably targeted and powerful anti-inflammatory punch then.
It really is.
It's quite fascinating how they mimic and amplify the body's own intricate regulatory systems to bring down that inflammatory response.
Indeed. They leverage existing pathways.
And this isn't exactly a groundbreaking new concept, is it, this approach? Can you give us a brief look at how these injections became such a staple in our field? What's their story?
No, you're right. Their use has a rich and influential history. The concept of injecting directly into muscle and joint inflammatory reactions gained significant popularity, thanks, in large part, to Janet Travel, MD.
Ah, yes. Known for her work on trigger points.
Exactly. She was a pioneering physician who really championed the concept of injecting directly into trigger points within muscles. It was a method she popularized to address localized pain and dysfunction, and she really laid much of the groundwork for modern injection therapy.
So it started quite focused.
It did. Initially, and still today, these injections were seen, and continue to be, a remarkably effective adjunct to other therapies. They're not a standalone cure, nor should they ever be viewed as such. That's correct.
Right. Not a magic bullet.
Definitely not.
Yeah.
Their true purpose, their real value, lies in their ability to provide significant and often rapid relief from inflammation and pain. This improvement then enables something critically important. It improves overall function and, crucially, facilitates rehabilitation.
Ah, so it's about creating an opportunity.
Precisely. Think of it as opening a vital window of opportunity. When a patient is experiencing debilitating pain, they often can't comfortably or effectively engage in physical therapy, targeted exercises, or other necessary interventions that actually address the underlying cause of their pain.
They're just too sore to do the work.
Exactly. The corticosteroid injection creates a temporary reprieve, reducing the pain to a manageable level so that the patient can then participate in those essential long-term rehabilitation strategies.
That makes perfect sense.
And moreover, in some chronic conditions, particularly those involving muscle trigger points and scar tissue, the injection itself can provide a degree of mechanical disruption and release pressure.
So the needle itself helps?
Potentially, yes. It contributes to the therapeutic effect, moving beyond just masking symptoms. This makes them a very powerful tool in a comprehensive treatment plan.
So it really sounds like the first step is less about the injection itself and more about being a thorough detective, piecing together the full clinical picture.
Absolutely spot on.
Before we even consider the needle, what's paramount in that history-taking and physical examination to ensure we're targeting the right pathology?
The diagnostic process is, in many ways, the most critical step. Before considering any injection, a careful patient history and a thorough, systematic physical examination are truly paramount.
Where do you start with the history?
We need to clearly differentiate between acute and chronic reactions. An acute presentation often involves sharp, severe, intense pain.
Like a recent injury flare-up.
Precisely, suggesting a more traumatic reaction with marked inflammation. In contrast, dull, low-grade chronic pain typically points to a milder, more long-standing inflammatory process.
Perhaps overuse or early OA.
Exactly. Perhaps an overuse injury or a degenerative condition like osteoarthritis.
And what about other symptoms?
We also need to be vigilant for pain radiation or any additional neurological symptoms, such as tingling, burning, or numbness.
Red flags for nerve involvement.
Yes, vital clues that imply nerve involvement, which might influence our injection strategy or even lead us towards other diagnostic avenues entirely.
Makes sense. What else in the history?
A thorough medication history is also important sometimes. Stopping or changing anti-inflammatory medications can precipitate a flare-up.
Right.
And even things like dietary changes can lead to conditions like an attack of gout, which we need to identify through careful questioning.
Okay. Then the examination.
On physical examination, identifying the exact location and severity of the inflammation is key. Is it clearly within a muscle, a specific tendon, or a particular joint?
Pinpointing the source.
Exactly. Developing excellent palpation skills to identify those precise trigger points in muscles is invaluable. Patients often know precisely where their greatest discomfort originates.
So they point right to it.
Often, yes.
Yeah.
And finding that tender, taut band is a clear sign.
What about imaging or labs at this stage?
Well, initial radiographic studies may not always immediately show an injury, especially with early soft tissue issues like effusions.
Right. X-rays show bone best.
Primarily. But they are nonetheless vital. They help us evaluate for fractures or determine the acuity of a condition. For instance, if we see significant joint and cartilage damage on a radiograph, it immediately tells us we're dealing with a long-standing degenerative process.
It gives you the background picture.
Precisely. Electromyograms, or EMGs, are incredibly beneficial if we suspect a significant neurological component to the patient's symptoms.
To check the nerve function.
Yes, helping us to differentiate nerve entrapment or irritation from purely musculoskeletal pain, and thus target injection sites more effectively if needed.
Okay. And blood tests?
Blood work, too, can provide critical clues. An elevated white blood cell count might indicate an underlying infection, a definite contraindication for injection.
Crucial point.
A high erythrocyte sedimentation rate, or C-reactive protein, suggests a significant myopathic or arthritic inflammatory process. Elevated rheumatoid factor can point towards chronic arthritic conditions like rheumatoid arthritis.
And gout.
Uric acid levels, of course, are crucial when considering gout. It's truly about bringing together all these pieces of information history, exam, imaging, labs to form a holistic, accurate assessment.
A proper diagnostic workup. So once that diagnostic compass is set and we have a clear picture, let's talk about the next step. Selecting the right corticosteroid and determining the optimal dose. What are the key considerations there?
Right. Once the diagnosis is firmly established, the choice of corticosteroid, its precise dosage, and the volume for injection are typically guided by the specific condition being treated, the joint in question, and certainly the clinician's experience plays a role.
Are there common choices?
Yes. The most commonly used medications in this setting are triamcinolone, often referred to as TA, and methylprednisolone acetate or MPA.
And the doses?
Dosages can vary quite a bit depending on the size of the joint or the extent of the inflammatory area, typically ranging from 20 to 80 milligrams for triamcinolone and generally 20 to 40 milligrams for methylprednisolone.
Is there a guiding principle?
What's paramount here, above all, is balancing the potential for effective relief with the crucial aspect of patient safety, always aiming for the lowest effective dose.
Okay. And is there much evidence to say one type is better than another for putting in the joint?
That's a very important point for our clinical practice. There's actually little consensus in the available evidence to definitively guide the selection of one intra-articular corticosteroid or IACS over another when it comes to overall efficacy.
Really? So they're much of a muchness?
Broadly speaking, yes. Studies generally show similar overall effectiveness across different preparations. While some, like triamcinolone hexacetonide, might appear to have a slightly faster onset of action, this isn't consistently borne out as a significant clinical advantage.
Interesting. What about those longer-acting ones?
Well, interestingly, extended-release preparations haven't demonstrated a clear clinical superiority over standard ones, in most cases.
I might have expected them to last longer.
You might think so, but the evidence isn't strongly supportive for most outcomes. However, there is one notable exception that's quite relevant for a significant patient population.
Thick is.
Extended-release options can provide better blood glucose stability in diabetic patients.
Ah, that's a very useful point.
It is. It's a tangible advantage in managing their condition post-injection. So the key insight here for our clinical practice isn't necessarily about finding the best corticosteroid based on the drug itself, but recognizing that their effectiveness is broadly similar.
Which frees us up to consider other factors.
Exactly. Like specific patient comorbidities, such as diabetes, where certain formulations might offer a practical advantage.
That's a crucial distinction. And what about the flip side of dosing? How often can we offer these injections? There's often understandable concern both from us and from patients about repeat administrations.
Yes, and that's a critical safety consideration that we must always keep top of mind. The general expert consensus recommends limiting intra-articular corticosteroid injections to a maximum of 4 times per year in a single joint.
For a year, max? And spacing?
Crucially, these injections should be spaced at least 3 months apart.
Why that time frame?
This recommendation is primarily aimed at reducing the potential risks associated with more frequent administration. Things like the gradual weakening of bones surrounding the joint, or perhaps an increased susceptibility to infection within the joint space itself.
Okay, makes sense. Are there exceptions? Athletes, perhaps?
Well, we do encounter specific conditions or patient populations that might seemingly necessitate more frequent injections. For instance, in professional athletes who rely heavily on their physical function and often face significant time pressures for recovery.
Yes.
A careful evaluation and a thorough, nuanced discussion involving healthcare specialists are absolutely essential. You have to weigh the benefits against the risks very carefully and try to mitigate potential adverse effects.
A very individualized decision.
Absolutely. It's also important to remember that the decision to repeat an injection shouldn't be based on a routine, pre-scheduled series, like come back in 6 weeks.
It should be symptom-driven?
Exactly. It should be driven by the patient's individual clinical response and when their pain genuinely recurs to a level that warrants further intervention.
Okay.
While the general guidance suggests that 3-month interval based on pharmacokinetic data, how the drug behaves in the body, a minimum interval of 2 to 3 weeks, up to 3 months, is sometimes suggested in specific circumstances, always with caution.
And do the big guideline bodies agree on this?
Mostly, but with subtle differences, which again underlines the need for clinical judgment. The American College of Rheumatology, or ACR for example, provides strong recommendations for intra-articular corticosteroid injections in both hip and knee osteoarthritis.
Okay.
In contrast, the American Academy of Orthopedic Surgeons, AAOS, is a bit more cautious, stating that they could be considered.
A slightly weaker recommendation.
Yes. The European League Against Rheumatism, EOR, recommends them for acute exacerbations of knee pain, especially if there's an effusion swelling in the joint where that immediate anti-inflammatory effect is highly beneficial.
You're right, for flare-ups.
Precisely. However, the Osteoarthritis Research Society International, ORSI, conditionally recommends IACS for knee OA, but explicitly not for hip OA.
Oh, why not the hip, according to RSI?
They cite a relative lack of robust, high-quality hip-specific trials compared to the knee. So understanding these subtle differences across guidelines is key for navigating clinical practice.
It's a really valuable point that the guidelines aren't perfectly uniform, highlighting the art and science of medicine here.
Indeed.
And it brings us to a fundamental question. These injections aren't a magic bullet, are they? We touched on this, but how do they truly fit into a broader, holistic treatment plan?
You've hit on a crucial truth there. Corticosteroid injections are emphatically not a magic bullet, nor are they a replacement for comprehensive rehabilitation. That cannot be stressed enough.
So what is their role then?
Instead, their true value, as we touched on earlier, lies in their ability to facilitate a patient's participation in physical therapy or other structured rehabilitation programs.
By reducing the pain enough to do the exercises.
Exactly. By significantly reducing acute pain and inflammation, they open that critical window where the patient can more comfortably and effectively engage in the necessary exercises, stretches, and movements that address the underlying causes of their musculoskeletal pain.
Right.
Without this follow-through, the injection is often just a temporary fix, potentially masking symptoms without addressing the root problem.
So you need the rehab component.
Absolutely. Incorporating manual rehabilitation, functional exercise, and progressive loading into the treatment plan is absolutely essential for achieving long-term health, sustained improvement in function, and crucially, preventing future injuries and recurrences.
So it's part of a package deal.
A truly comprehensive, multidisciplinary approach is always key. This often includes a thoughtful combination of treatments. Non-steroidal anti-inflammatory drugs, or NSAIDs, can manage more diffuse inflammation. Sometimes a short course of oral prednisone might be considered for more widespread inflammatory conditions before localizing treatment. Non-narcotic pain medications, perhaps like amitriptyline, which many of us know as Elavil, can also be beneficial in reducing pain associated with chronic inflammatory reactions or neuropathic component.
Okay.
And of course, the fundamental supportive measures remain vital. Appropriate rest, regular application of ice, perhaps heat for muscle relaxation.
Simple things.
Often the most effective. Splinting or bracing, where appropriate, can provide crucial support and immobilization.
Right.
Then, as the acute inflammation subsides and the injection's effects kick in, physical therapy and massage therapy become increasingly effective, leading a patient towards a more general long-term rehabilitation management strategy focused on restoring strength, flexibility, and proper biomechanics.
It truly is about building that comprehensive toolkit.
And deploying each tool at the right time.
That makes perfect sense. Now, let's turn to the practical side of things. Once we've made the decision to inject, what are the absolute best practices for performing the injection itself? How do we ensure a smooth, safe procedure for our patients?
Right, the procedure itself. Our primary objective is always to deliver the corticosteroid to the precise target area with minimal pain and, crucially, as few complications as possible.
Precision and safety.
Exactly. This necessitates meticulous site selection, paying careful attention to both the surface anatomy and the deeper underlying structures. It's vital to avoid injecting near known nerve or arterial landmarks. For example, when injecting around the medial epicondyle of the elbow, extreme care is required due to its close proximity to the ulnar nerve. Inadvertent injury there can lead to significant and prolonged discomfort.
Definitely want to avoid that. What about infection risk?
Absolutely essential is adhering to a strict sterile technique, particularly for intra-articular injections, where the risk of introducing infection, though rare, can have devastating consequences.
So proper skin prep.
Yes, ensuring that any antiseptic solution, such as povidone iodine, dries fully on the skin to achieve its maximum antibacterial effect before needle insertion.
Good tip about letting it dry.
It's crucial for efficacy. And another critical tip is to consider changing the needle used to draw the medication from the vial with the one used for the actual injection itself. especially when using multi-dose vials.
No, why is that?
It helps maintain the highest level of sterility, preventing any potential contamination from the rubber stopper or the air when drawing up.
Makes sense. I've heard debate about using one needle versus two for the whole process.
Yes, there's often a common discussion in practice regarding the two-needle versus one-needle technique. Some physicians prefer using a single needle to minimize patient discomfort and the number of skin punctures.
Sounds reasonable.
However, cortisone preparations are typically quite viscous or thicker.
Right, they can be hard to push.
Exactly, which often necessitates a larger gauge needle for smooth injection, and this can inherently be more painful upon insertion.
Ah, the catch.
Personally, I find a two-needle technique is often better tolerated by patients and provides a smoother experience.
How does that work?
It involves first anesthetizing the skin and superficial tissues with a small, fine 25-gauge needle containing local anesthetic.
What?
You wait 3 to 5 minutes for that to take full effect.
Numb the area first.
Precisely. Once the area is numb, we can then proceed with a slightly larger 21 or 22-gauge needle for the corticosteroid, which can pass through the now anesthetized tissue much more comfortably.
Okay, that sounds logical. What actually goes in the syringe? Just the steroid.
As for the injectate composition, this is often left to the physician's clinical discretion and personal experience. Many practitioners prefer a simple, long-acting methylprednisolone preparation.
In your preference?
My personal preference, honed over years of practice, is a cocktail of equal parts. Lidocaine for immediate pain relief.
Comfort during and straight after.
Yes. Then triamcinolone, which is an intermediate-acting corticosteroid, typically at 40 milligrams per milliliter, and dexamethasone, which is a long-acting corticosteroid at 4 milligrams per milliliter.
So a mix for immediate and longer relief.
That's the aim, yes, to provide both immediate comfort and sustained anti-inflammatory effects.
And does the technique differ depending on where you're injecting, muscle versus joint?
Absolutely. For muscle trigger points, the needle is inserted directly into the palpable taut band or trigger point.
Right into the knot.
Essentially, yes. But it is absolutely crucial to always withdraw the plunger slightly before injecting.
Aspirate.
Yes, to confirm that a blood vessel hasn't been penetrated, preventing inadvertent intravascular injection.
Very important check.
Critical. The needle can then be moved up and down gently, fanning it into 3 or 4 different areas within the trigger point itself. Part of the therapeutic benefit here, beyond the pharmacological effect, might be the mechanical disruption of scar tissue and taut muscle fibers.
Okay. What about near tendons?
For periarticular injections, it's critical not to inject directly into the tendon substance itself.
Why not?
This can lead to mechanical disruption, weakening, or even that rare but serious risk of tendon rupture we mentioned.
Right. Avoid the tendon itself.
Yes. Instead, aim to inject small droplets around the inflamed area into the tendon sheath or surrounding tissues. Multiple small injections might be needed to adequately cover several centimeters of an inflamed tendon or muscle belly.
And for joints?
Joint injections require direct insertion into the joint space itself. You often feel a give or lack of resistance once the needle enters the synovial cavity, which helps confirm placement.
Okay. And what happens after the needle comes out? What should we tell the patient?
Meticulous post-injection care, and perhaps most importantly, setting accurate patient expectations are vital for patient satisfaction and adherence. I always recommend immediate icing of the injected area.
Why ice straight away?
The injection itself, despite our best efforts, is a traumatic event at a cellular level. It can cause localized swelling and edema, somewhat ironically, the very problems we're trying to treat. Immediate icing helps to mitigate this acute inflammatory response.
Makes sense. What about pain levels afterwards?
This is crucial. Patients absolutely must be warned about what to expect in the hours and days following the injection. For the first couple of hours, they'll likely feel very comfortable due to the local anesthetic.
Lidocaine kicking in.
Exactly. But this comfort is temporary, usually lasting only about 2 hours. Once the local anesthetic wears off, it will often be replaced by increased pain, sometimes described as a steroid flare.
Worse than before.
It can actually be worse than the pain they experienced before the injection. This tenderness or flare-up often lasts for about 2 days.
Right. Need to manage expectations there.
Absolutely. Tell them to manage it at home, primarily with ice and paracetamol. Warning patients upfront about this anticipated post-injection pain can prevent many unnecessary panic calls and manage their anxiety significantly.
Good advice. Any warning signs they should call about?
Of course. They must also be cautioned to seek immediate evaluation for any unexpected and concerning symptoms. excessive bleeding that doesn't stop with pressure, signs of an allergic reaction like rash or difficulty breathing, or any systemic symptoms like chest tightness or wheezing, or indeed signs of infection like increasing redness, heat, and fever later on.
Standard red flags. And you mentioned frequency earlier, 3 per year for joints. Is it different for trigger points?
Yes, regarding the frequency, as we discussed, for general tendon and joint injections, we generally limit them to no more than 3 per joint per calendar year, precisely due to the potential for mechanical disruption.
Right.
For trigger points, however, which are often more about muscle dysfunction and fascial pain, it's common for multiple injections to be required for comprehensive treatment. For simple trigger point issues, typically 3 sets of injections might be needed, spaced perhaps a week or 2 apart. However, in more chronic muscle disorders, like fibromyalgia or myofascial pain syndrome, I've sometimes seen patients benefit from up to 10 rounds over several weeks. They often note a new worst spot appearing each week as other areas resolve.
Interesting. So it depends on the underlying issue.
Very much so.
That attention to detail, both in technique and patient counseling, is clearly paramount. And speaking of precision, this brings us perfectly to imaging guidance. How does using tools like ultrasound or fluoroscopy change the game for injection accuracy and, critically, for patient outcomes?
Yes, imaging guidance. The evidence base increasingly favors ultrasound guidance for corticosteroid joint and soft tissue injections,
Why is that?
for 2 main reasons: demonstrably improved accuracy and often for better short-term clinical outcomes. Studies have consistently shown that U.S.-guided injections are significantly more accurate than landmark-guided approaches.
Can you give an example?
Certainly. One study found 83% accuracy for U.S.-guided injections in inflammatory arthritis, compared to just 66% with clinical examination guidance. Another study on knee injections using a superlateral approach achieved an impressive 100% accuracy with U.S. guidance.
That's quite a difference. Does it feel different for the patient?
Well, this enhanced precision often translates directly into reduced procedural pain for the patient, as we're hitting the target more consistently first time. And importantly, it leads to improved performance and better immediate clinical outcomes, particularly for intra-articular joint injections.
So better results straight away.
Often, yes. Systematic reviews and meta-analyses broadly confirm this. Greater accuracy and better short-term clinical outcomes with U.S. guidance.
But is there a catch? Does it matter long-term?
That's an important nuance. It's crucial to note that many studies show no significant long-term difference in overall outcomes when comparing U.S.-guided versus landmark-guided techniques.
Interesting. So the immediate benefit doesn't always last.
It suggests that while getting the medication in precisely the right spot is important for immediate relief, for long-term management, other factors like rehabilitation, activity modification, and the underlying disease progression often become more dominant drivers of outcome.
Right. The injection is only one part of the puzzle.
Exactly. So while landmark techniques may be sufficient and effective for some more superficial injections, perhaps the trochanteric bursa,
Where you can feel it easily?
yes, their accuracy can be highly questionable for more complex or deeper joints like the shoulder or the hip, or in patients with altered anatomy, perhaps due to obesity.
So when would you definitely favor imaging?
Imaging guidance may be preferred, particularly for ensuring accuracy in those challenging cases, like morbid obesity where landmarks are unreliable. And it might also be associated with fewer adverse events simply due to a reduced need for multiple attempts or hitting nearby structures. So the key insight here is that ultrasound guidance provides confidence in precise delivery, which translates to better immediate results and reduced discomfort, even if the long-term journey for the patient is shaped by broader factors.
It sounds like precision truly matters, particularly for that initial, crucial patient experience and immediate relief. Let's delve into some specific joints that our audience, working in orthopedics, frequently encounters, starting with the shoulder. What are the key considerations and evidence points there?
Certainly. The shoulder is a very common area for chronic pain presentations, and its underlying causes are quite varied, aren't they?
Absolutely. Rotator cuff, OA, frozen shoulder.
Exactly. We frequently see acromioclavicular or AC, and glenohumeral or GH, osteoarthritis, various rotator cuff disorders including tendinopathy and tears, adhesive capsulitis, what many of us colloquially call frozen shoulder, and also instability issues.
So lots of potential targets for injection.
Precisely. Common injection sites for shoulder pain reflect this diversity.
Yeah.
We inject into the acromioclavicular joint, the glenohumeral joint itself, the subacromial subdeltoid bursa, that's the SDB, the long head of the biceps tendon, and even occasionally the scapulothoracic bursa.
Okay. What about for frozen shoulder adhesive capsulitis? Where is best to inject?
For adhesive capsulitis, there's been some interesting debate regarding whether intra-articular corticosteroid injections into the GH joint or subacromial subdeltoid bursa injections are superior. The findings are a bit mixed.
No clear winner.
Not definitively. Some meta-analyses suggest that intra-articular injections might reduce pain more effectively for up to 3 months, while others show no significant difference between the two approaches. Ultimately, the conclusion often is that either approach can be a viable initial strategy.
Okay. And does ultrasound help for shoulder injections?
When comparing image-guided versus landmark-guided shoulder injections, an early retrospective study did show better outcomes for ultrasound-guided AC joint injections.
Right.
A Cochrane review also found better pain outcomes at 6 weeks with image-guided injections, but this statistical significance often disappeared when inadequately blinded trials were excluded from the analysis.
The quality of studies matters.
Always. And more recent, robust, double-blind, randomized controlled trials have actually shown no difference in overall clinical outcomes between U.S.-guided and landmark, despite the confirmed greater accuracy achieved with U.S. guidance.
So even if you hit the spot perfectly, it doesn't always change the final result.
For some shoulder conditions, it appears that way. It highlights that while precision is desirable, functional outcomes may not hinge entirely on millimeter-perfect placement in every case.
Fascinating. What about the dose for the shoulder? Does more mean better?
Regarding dose response in the shoulder, an intriguing finding is that there's often no significant difference in efficacy between 20 milligrams, 40 milligrams, and even 80 milligrams of triamcinolone when injected into the glenohumeral joint.
Really? 20 milligram works as well as 80 milligrams?
For reducing the SPATI score at 6 months, studies have shown that. Similarly, 20 milligrams and 40 milligrams of triamcinolone have been found to be equally effective for adhesive capsulitis and general shoulder stiffness.
So the key insight there is?
Use the lowest effective dose. A lower dose may be perfectly sufficient, potentially mitigating some risk without compromising efficacy.
Good principle. What about the biceps tendon? That's a common one.
Yes, the bicep tendon sheath is another frequent target, especially for patients complaining of anterior shoulder pain. Ultrasound guidance significantly improves accuracy here.
How much better?
Reported rates are around 87% accuracy with US compared to just 27% with landmark techniques.
Wow, that's a huge difference.
It is. And this increased accuracy translates into significantly better pain relief and functional improvement. Crucially, ultrasound allows for the direct visualization of important structures, like the anterior circumflex artery.
So you can avoid hitting it.
Precisely. Doses for biceps tendon sheath injections are often 40 milligrams of triamcinolone, and paratendinous corticosteroid injections have even been used cautiously for partial biceps tendon tears, aiming to reduce local inflammation around the tear.
Okay, moving down the arm to the elbow. Tennis elbow.
Lateral epicondylosis, yes. For tennis elbow, corticosteroid injections do provide useful short-term pain relief, typically lasting less than 8 weeks.
Short-term relief is good, but,
and this is a critical takeaway for patient counseling, they are generally less effective in the long term compared to comprehensive physical therapy or even NSAIDs, and regrettably, they're associated with a higher recurrence rate once their effect wears off.
so they might feel better initially, but the problem comes back more often.
That's what the evidence suggests. It strongly points to their role as a bridge to other therapies, perhaps to allow effective physio rather than being a standalone solution.
Right.
Combining a corticosteroid with a local anesthetic has shown better immediate efficacy than local anesthetic alone, which makes sense for procedural comfort.
What about the other side, golfer's elbow?
For medial epicondylosis, or golfer's elbow, there's less robust research available, so strong recommendations are scarce. It's often managed similarly, but with less evidence to guide us.
And olecranon bursitis, the big swelling at the back of the elbow?
Yes, for olecranon bursitis, which is often acutely painful and swollen, aspiration drawing the fluid off combined with a corticosteroid injection has consistently shown the earliest mean resolution of symptoms.
How much faster?
Typically within about 2.3 weeks, which is significantly faster compared to aspiration alone or just using NSAIDs.
Okay, let's move to the hip. What are the main reasons for injections there?
The hip is another common site of pain, most frequently due to osteoarthritis, overlay, or greater trochanteric pain syndrome. GTPS, often called trochanteric bursitis, though it's usually more tendinopathy.
Right.
Other causes we encounter include osteonecrosis, femoral acetabular impingement, FAI, or labral tears.
And how effective are injections for hip OA?
For intra-articular corticosteroid injections in hip osteoarthritis, randomized controlled trials consistently demonstrate significant short-term improvement,
How long does that last?
usually up to 3 months, showing benefits in both pain and function as measured by things like the WM index. This makes them a valuable option for acute flares or to provide relief while awaiting definitive treatment like surgery.
Are steroids better than other types of hip injections, like NSAIDs or hyaluronic acid?
Well, when comparing corticosteroids to non-corticosteroid injections like intra-articular ketorolac, there's often no significant difference found in efficacy for hip OA.
Interesting.
However, corticosteroids have generally shown better short-term pain relief than hyaluronic acid, especially when there's an effusion present at the joint.
Okay, what about newer things like PRP?
Newer therapies like platelet-rich plasma or PRP may offer better long-term outcomes, perhaps at 6 months in some network meta-analyses for OA, but corticosteroids are generally preferred for their quicker, more immediate short-term relief.
So steroid for fast relief, maybe PRP for longer term?
That's a reasonable summary of the current thinking, yes. Steroids are useful when rapid symptom control is the priority.
What about that trochanteric pain, GTPS?
For GTPS, the studies are quite heterogeneous, making firm conclusions tricky. But corticosteroid injections are generally considered a reasonable initial therapy.
How do they compare to other treatments?
Their efficacy seems comparable to things like dry needling or shockwave therapy for short-term relief. However, similar to tennis elbow, PRP might offer better long-term outcomes for chronic gluteus medius or minimus tendinopathy, which often underlies GTPS.
Okay. And other hip area injections?
Yes, ultrasound-guided corticosteroid injections into the iliopsoas bursa can also provide significant pain relief for conditions like iliopsoas tendinopathy or bursitis, often causing groin pain.
Does ultrasound help much for hip injections generally?
In terms of imaging for hip injections, ultrasound guidance generally offers better accuracy for the trochanteric bursa, maybe 92% compared to 67% with landmark techniques, though this difference isn't always statistically significant across all studies. Fluoroscopy-guided injections are also highly effective, particularly for getting right inside the hip joint, intra-articular, which could be tricky otherwise. Ultrasound guidance is particularly recommended for injections around tendons like the gluteals or into the iliopsoas bursa to ensure precise placement and avoid nearby nerves and vessels.
Okay, turning finally to the knee, probably the most commonly injected joint.
Very likely, yes. Intra-articular corticosteroid injections for knee osteoarthritis receive strong recommendations from the ACR, the rheumatology body.
And the orthopedic surgeons.
The AOS states they could be considered, so slightly more reserved. ELIAR, the European group, recommends them for acute exacerbations, especially if there's an effusion, that's swelling again.
So good for flare-ups. Does using ultrasound make a difference in the knee?
Yes. When comparing landmark versus image-guided knee injections, ultrasound guidance generally leads to greater improvement in pain, patient satisfaction, and quality of life at 4 to 6 weeks post-injection.
And accuracy.
U.S. guidance is also significantly more accurate. For example, one study achieved 93% accuracy for a lateral midpatellar approach with ultrasound, compared to 75% for a standard anteromedial landmark approach. This increased accuracy likely contributes to the better immediate outcomes.
Does the dose matter much in the knee? Like the shoulder?
Similarly to the shoulder, yes. 40 milligrams of triamcinolone acetonide has been found to be just as effective as 80 milligrams for intra-articular knee injections.
Reinforcing that lowest effective dose principle.
Exactly. And again, no particular long-term superiority of any specific corticosteroid preparation has been consistently demonstrated. The relief provided is typically short-term.
How short-term?
Usually lasting up to 6 weeks, may be extending to 12 weeks in some cases, which aligns well with the pharmacokinetic peak and half-life of the medication.
Okay. Do patients need to rest their knee after an injection?
Regarding post-injection protocols, there's actually no clear benefit demonstrated for prescribing rigid rest or splinting after a knee injection.
Really? No need to take it easy.
The evidence doesn't strongly support it for improving outcomes. In fact, some studies even suggest strict rest might increase the recurrence rate in pediatric patients with inflammatory arthritis, which is an interesting finding. So general advice is often just to avoid strenuous activity for a day or two.
Good to know. Lastly, what about the smaller joints? Hand, wrist, foot.
Yes, these are frequently encountered in primary care, rheumatology, and orthopedics. For hand and wrist injections, ultrasound guidance has consistently been shown to be superior to landmark-based techniques.
Makes sense. They're small targets.
Exactly. Enhanced precision is very helpful. Interestingly, though, intra-articular corticosteroid injections for carpometacarpal, CMC osteoarthritis, that base of thumb arthritis, haven't consistently shown robust long-term improvement in high-quality studies.
Oh, so maybe less effective there long term.
It seems that way from the current evidence. However, they can lead to less pain with movement in interphalangeal osteoarthritis affecting the finger joints, which is certainly valuable for daily function.
Okay. What about trigger finger?
For trigger finger, there's moderate evidence for a significant short-term benefit, typically lasting 0 to 3 months. It often provides considerable relief from that catching and pain.
Does the dose matter for trigger finger?
Studies suggest that 20 milligrams of triamcinolone is more effective than lower doses for this condition. And interestingly, there's no significant difference found in efficacy between ultrasound-guided and palpation-guided injections.
So you can probably just feel for it.
It suggests a landmark approach is often sufficient, given how superficial the structures are.
Okay. Decre veins, that wrist tendon issue.
Yes, Decre veins tenosynovitis also shows moderate short-term benefit, again within that 0 to 3 month window. The combination of using a thumb splint with a corticosteroid injection has been shown to lead to more sustained intermediate-term improvement, often lasting 4 to 6 months.
So the splint helps maintain the benefit.
It seems so.
And finally, down to the foot plantar fasciitis. Heel pain.
Ah, the bane of many people's lives. Corticosteroid injections are supported for use over placebo or no treatment, but this benefit is typically limited to up to 1 month.
Only a month.
Often, yes, and it's a critical distinction that they are generally not found to be more effective than placebo for non-inflammatory heel pain. Their efficacy is really in treating the inflammation.
So not for mechanical heel pain.
Correct. However, they are beneficial for rheumatic inflammatory heel pain, such as that associated with spondyloarthritis, where the pain is due to true enthesitis inflammation where the tendon or ligament inserts into bone.
Ah, important distinction. What about long-term for plantar fasciitis?
In the long term, platelet-rich plasma, PRP, and dry needling may offer superior outcomes compared to corticosteroids for chronic plantar fasciitis, based on emerging evidence.
That deep dive into specific joints really underscores the need for a nuanced, evidence-based approach, and definitely not a one-size-fits-all mentality.
Absolutely. Each joint, each condition, each patient is different.
Now, every intervention carries its own set of considerations and potential risks, and corticosteroid injections are certainly no exception. What are the absolute and relative contraindications we must be acutely mindful of before proceeding?
This is perhaps the most crucial segment of our discussion, as understanding contraindications and potential adverse events is absolutely paramount for patient safety.
Let's start with the absolute no-goes.
For absolute contraindications, we must never inject if there's an overlying skin infection at the injection site, or if we suspect an infectious arthritis, a septic joint within the joint itself.
Why not?
Introducing corticosteroids into an infected joint can rapidly worsen the infection, potentially leading to joint destruction. It's a disaster.
Right. Never inject into infection. What else?
Similarly, we must avoid injecting directly into a known acute fracture site, suspected bacteremia, meaning a systemic bacterial infection circulating the blood.
Like sepsis.
Yes, or leading to it. That's an absolute contraindication.
Yeah.
And of course, a history of hypersensitivity or serious allergic reactions to previous corticosteroid injectables. The risk clearly outweighs any potential benefit.
Okay, those are the definites. What about the maybe not situations, the relative contraindications?
Right, the relative contraindications. These are situations where we need to proceed with extreme caution, carefully weighing the potential risks against the anticipated benefits and engaging in really thorough shared decision-making with the patient.
Such as?
These include a previous lack of efficacy with an injection in the same area. If it didn't work before, it's unlikely to work much better now.
Makes sense.
A severely immunocompromised status, perhaps patients on high-dose immunosuppressants or with certain autoimmune diseases, raises the risk of infection post-injection.
We need to be cautious there.
Similarly, patients with a coagulopathy, whether inherited or due to medications like warfarin, need careful assessment of bleeding risk, though, as we'll discuss, this risk is generally quite low for peripheral injections.
Okay. What about joint replacements or diabetes?
Injecting into a joint with a prosthesis requires careful consideration and is often avoided unless absolutely necessary and after discussion with the surgeon. Poorly controlled diabetes is another relative contraindication due to the blood sugar effects we'll cover.
Right.
We also need to be very wary in patients with significant surrounding joint osteoporosis, as the integrity of the bone may be compromised.
And tendons again.
And critically, for certain specific tendinopathies, particularly patellar or Achilles tendinopathies, there's that rare but definite risk of tendon rupture following corticosteroid injection. This risk often leads us to strongly consider alternative treatments for these specific tendon pathologies first.
That's a comprehensive list of situations to be cautious about. Beyond those immediate contraindications, what are the local concerns for the joint itself, particularly when we're considering repeat injections? What effects might we see on cartilage or tendons over time?
That's a vital question, because the local effects on the joint can be quite significant, especially with frequent or high-dose injections. One of the primary, most significant concerns, particularly for us at orthopedics and rheumatology, is the potential detrimental effect on cartilage health.
How do they harm cartilage?
Corticosteroids can exert catabolic effects, meaning breaking down on key cartilage proteins. These are the very building blocks that give cartilage its strength, elasticity, and shock-absorbing capabilities, things like aggrecan and type 2 collagen, as well as proteoglycans.
So they weaken the structure.
Potentially, yes. This can affect the availability and health of chondrocytes, the cells that maintain cartilage, and can even impact the gross morphology or structure of the cartilage itself over time.
Is this proven?
Basic science and animal studies, particularly with commonly used preparations like methylprednisolone, betamethasone, and triamcinolone, have demonstrated a clear, dose-dependent detrimental effect on cartilage.
And in humans.
Some human studies, especially more recent ones, have shown an association with accelerated osteoarthritis progression, particularly in the hip and knee. And even rare but serious cases of rapid joint destruction, sometimes called rapidly progressive osteoarthritis, have been reported after intra-articular corticosteroid injections, especially with higher doses or multiple injections.
So it's quite worrying.
It certainly reinforces the clinical principle of always using the minimum effective dose and strictly limiting the frequency of injections.
Right. What about tendons again? We mentioned rupture risk with certain ones.
Yes, another significant local concern, although thankfully rare, is tendon rupture. This has been reported in various tendons, biceps, Achilles, patellar tendons, for example, following corticosteroid injection, particularly if injected directly into the tendon substance rather than around it.
Can it cause a tear to worsen?
While infrequent, these can be very serious complications, sometimes progressing from a partial tear to a complete rupture, potentially necessitating surgical repair. This is why meticulous technique, ensuring peritendinous rather than intratendinous injection, is so crucial.
Okay. Any other local reactions?
Lastly, we must be aware of sterile inflammatory arthritis, sometimes called post-injection flare, but more severe.
What's that?
This presents as acute, severe post-injection swelling and pain that can clinically mimic septic arthritis, which, as you know, is a dire medical emergency requiring urgent washout.
So it looks like an infection, but isn't.
Exactly. Sterile inflammatory arthritis is an aseptic process, meaning no infection is present. It's possibly caused by an exacerbation of crystals, like calcium pyrophosphate dihydrate crystals, the ones in pseudogout, within the joint. They might be dislodged by the injection or even precipitated by the corticosteroid itself.
How do you tell the difference?
It's difficult clinically. This is why a careful and thorough clinical assessment, often including joint aspiration and fluid analysis for cell count, gram stain, and crystals, is absolutely crucial if a patient presents with significantly increased pain, swelling, and redness post-injection to definitively rule out infection.
Got it. Those local effects, particularly on cartilage and tendons, are certainly concerning and directly impact our long-term patient management. But what about the systemic effects? How does this local injection actually impact the rest of the body, beyond the joint itself?
That's a critical point because despite being a local injection, there is systemic absorption of the corticosteroid and therefore potential systemic effects that we need to counsel patients about.
Like what? What's the most common?
One of the most clinically significant systemic effects we frequently encounter is on blood glucose levels. Clinically significant increases in blood glucose can occur, particularly in diabetic patients.
How soon and for how long?
While the effect can sometimes be noted within hours, the peak blood glucose increase may be delayed for up to 2 days post-injection, and importantly, can persist for up to 7 days in some individuals.
So diabetic patients really need to know this.
Absolutely. They must be advised to monitor their blood glucose carefully for at least 48 hours and potentially for up to a week until their levels normalize and adjust their diabetes medication if necessary, often in consultation with their GP or diabetic team.
Does the type of steroid matter here?
Interestingly, as we discussed earlier, those extended-release corticosteroid formulations may help mitigate this blood glucose fluctuation in diabetic patients, offering a more stable profile. That's one potential advantage for them.
Okay. What else systemically?
Another systemic concern, albeit uncommon, is adrenal suppression.
The body stops making its own cortisol.
Essentially, yes. This
Oh.
can occur even after a single intra-articular dose of corticosteroids due to suppression of the hypothalamic pituitary adrenal HPA axis.
Is that serious?
While clinically meaningful adrenal insufficiency is infrequent, it's an important condition to be aware of, particularly in situations of physiological stress for the patient, like if they need surgery or have a severe illness shortly after the injection, where it could potentially lead to symptoms such as hypotension.
Should we test for it?
Routine cortisol monitoring before or after injections is generally not recommended due to its low incidence and often transient nature. However, in the right clinical setting, if a patient presents with unexplained hypotension or other signs suggestive of an adrenal crisis in the days or weeks following an injection, it should certainly be considered in the differential diagnosis.
Right. What about bones? We know oral steroids affect bone density.
Bone mineral density, or BMD, is also a consideration, although the risk from intermittent local injections is generally thought to be much lower than from chronic oral corticosteroid use.
But is there still a risk?
Chronic or high-dose systemic corticosteroid exposure is well known to affect BMD. For injections, some have suggested maximum cumulative whole-body triamcinolone equivalent doses, perhaps around 200 milligrams per year and 400 milligrams over 3 years in postmenopausal women, as a cautious approach.
Balancing safety and benefit.
Exactly. However, a large recent study provides some reassurance. It found no statistically significant association between corticosteroid injections into various joints and an increased fracture risk, even with varying cumulative doses.
So maybe not as big a risk as previously thought.
The risk appears low from injections alone, but prudence, particularly in those already at high risk for osteoporosis, remains key.
Any other unusual systemic effects?
There are a few less common but notable ones. Intriguingly, intra-articular corticosteroid injections can potentially diminish the efficacy of influenza vaccinations if administered concurrently or very close in time.
So maybe avoid injecting right before their flu jab.
It might be prudent, yes. Patients injected immediately before or during flu season might face an increased, albeit small, risk of developing influenza compared to those not injected.
Okay. Anything else?
And quite surprisingly, perhaps, a study found a link between corticosteroid injections for joint or back pain and abnormal vaginal bleeding in postmenopausal women.
Really? How strong was the link?
This study reported 17% experiencing this, compared to 7% in controls. It highlights the broad and sometimes unexpected systemic reach of these agents, underscoring the need for careful patient counseling on all potential side effects, even seemingly unrelated ones.
That's quite a comprehensive overview of the systemic implications. And this next point is a truly big one for orthopedic surgeons. How do these injections influence the risk of paraprosthetic joint infection, or PJI, if a patient later needs a total joint replacement? It's a very common scenario.
This is indeed a critical concern, and one that weighs heavily on orthopedic surgeons and their patients planning arthroplasty. There's well-documented increased risk of postoperative deep joint infection PJI if an intra-articular corticosteroid injection is administered within 3 months prior to that total joint replacement surgery.
3 months. Is it worse if it's closer to the surgery date?
Yes, the risk is particularly elevated if the injection is performed within 1 month of surgery.
So what's the standard advice now?
Because of this evidence, there's now a very strong, almost universal consensus among orthopedic surgeons for a strict 3-month corticosteroid-free preoperative interval.
Okay, a clear 3-month gap needed.
Absolutely. The practical implication for us, the clinicians administering these injections, is that if you are considering an intra-articular corticosteroid injection for a joint that is potentially going to need replacement surgery within 3 months, for example, a patient with end-stage osteoarthritis who's on the waiting list,
Yes.
it is absolutely essential to have a frank and thorough discussion with the operating surgeon about these risks and benefits. Ideally, you should avoid the injection if surgery is planned within that 3-month window.
Communication with the surgical team is key.
Paramount.
What about giving steroids during the joint replacement surgery itself? I've heard of that being done.
That's an interesting point. The data surrounding intraoperative intra-articular corticosteroid injections tells a slightly different story.
Oh, so?
A systematic review found that when corticosteroids are administered intraoperatively during total knee or hip replacement, patients actually experienced superior analgesia and less postoperative nausea and vomiting.
Better pain relief and less sickness.
Yes, with no significant difference in adverse events, including infection, compared to saline injections.
Why would that be safer?
It's likely due to the highly sterile environment of the operating theater, where the risk of introducing external contamination is virtually eliminated compared to an outpatient clinic injection.
Makes sense. Is that true for all surgeries?
It's important to note, this isn't a universal finding across all procedures. For instance, an increased infection rate has been seen after intraoperative intra-articular corticosteroid injections in ankle arthroscopy. So context and the type of procedure really matters.
That nuance between preoperative and intraoperative use and across different joints is incredibly valuable. Finally, for patients on anticoagulants, warfarin, DOAC is a common clinical scenario. How do we manage the bleeding risk with these injections? Do we need to stop their medication?
For patients on anticoagulants, the good news is that the risk of clinically significant bleeding from peripheral joint and soft tissue injections is generally quite low.
How low are we talking?
One large retrospective study of over 500 patients on therapeutic warfarin who collectively underwent hundreds of joint injections found only a 0.2% rate of clinically significant bleeding, which is remarkably low.
That is very low. What about the newer drugs?
More recent studies involving patients on novel oral anticoagulants, or NOACs, have found virtually no incidence of bleeding whatsoever from these types of injections.
So generally safe to proceed.
The American Society of Regional Anesthesia and Pain Medicine, ASRA-PM, which provides widely accepted guidelines, actually suggests that for low bleeding risk procedures, such as peripheral joint injections, patients on anticoagulants and antiplatelet medications can often continue their medications without interruption.
No need to stop the warfarin or DOAC.
Generally not, as long as there are no additional complicating coagulopathic conditions like advanced liver disease or a pre-existing history of significant bleeding issues.
What's the reasoning?
The rationale here is clear. The risk of stopping these crucial medications, particularly for preventing potentially life-threatening thromboembolic events like strokes or deep vein thrombosis, often significantly outweighs the very low risk of bleeding associated with the injection itself.
That's reassuring.
It is. This is a common point of anxiety for both patients and clinicians, so understanding the evidence here is crucial for confident shared decision-making.
What a truly comprehensive deep dive today. We've unpacked the intricate cellular mechanisms of how corticosteroid injections work, the absolute importance of proper patient selection through meticulous history and examination.
A foundation.
Exactly. The crucial nuances of the injection procedure itself and the enhanced precision offered by imaging guidance. We've also meticulously detailed their applications across various specific joints, providing, I think, a valuable evidence-based guide for everyday practice.
Hopefully useful for listeners.
And crucially, we've navigated the essential precautions and potential adverse events, from the local concerns about cartilage and tendon health to the broader systemic effects and, significantly, the critical implications for future orthopedic surgery.
Covering the full spectrum.
It's abundantly clear that these injections are a powerful and incredibly valuable tool in our orthopedic arsenal, but their effective and, most importantly, safe use absolutely demands that thorough understanding of their mechanisms, proper patient selection, meticulous technique, and a keen awareness of both local and systemic risks.
It really does.
This truly underscores the importance of individualized patient care and shared decision-making in every single clinical encounter.
Exactly. My hope is that this discussion reinforces that these injections are most effective when they're not viewed as a standalone quick fix, but rather when they are carefully integrated into a comprehensive, multidisciplinary treatment plan.
Right. Back to that facilitation role.
Precisely. They offer a valuable window for recovery and rehabilitation, but that window must be leveraged effectively by both patient and clinician to achieve lasting benefit.
If this deep dive has helped you in your clinical practice, please consider taking a moment to rate and share our deep dive with a colleague who might also benefit. And for a final thought to ponder, given the well-established short-term benefits and the array of potential long-term risks, particularly concerning cartilage, how will advancements in personalized medicine and regenerative therapies, things like PRP or cell-based treatments, truly reshape and perhaps redefine the role of corticosteroid injections in musculoskeletal care over the next decade?
A fascinating question for the future.
It's certainly a conversation we'll be watching closely.